Dr. Dirkley. It's my pleasure to once again welcome Dr. Jean Ouellet. He's a clinical professor of pediatric surgery and chief of McGill Scoliosis Spine Group at McGill University Health Center. He's also a clinical director of scoliosis and spine surgery at Shriners Hospital for Children Canada and at Montreal's Children's Hospital. Currently, he's president of the Canadian Pediatric Spine Society as well. Looking forward to this presentation today on surgery for early onset scoliosis. Now, I've always been fascinated by early onset scoliosis because because there are many cases where you can actually cure scoliosis, with casting. But on the flip side, if the curves are severe or difficult to manage these cases, right? So you see such a spectrum at that particular age. And you have a system and a paper that you'll be publishing or already published. And I was wondering if you could talk a little bit more about the Trolly system and how it came to be, because I haven't really heard too much about it.
Yeah, it would be a great pleasure. The problem with that is that it's one of my topics that I enjoy, so you may have to cut me off because obviously, early onset scoliosis remains sort of unfortunately, the new frontier. The fact that there's so many different treatment means that we probably don't really know what we're doing, and that our ability to manage these kids is that they, even though they have a diagnosis, they have scoliosis and they're very young, they don't have the same disease. Some of them present completely different, and therefore it is ludicrous to think that there is one treatment for these kids, and therefore depending on the type of syndrome, depending on the type of scoliosis, the location of the curve, it really pushes physicians and surgeons to have to think outside of the box. And to a certain degree, I've been doing this for I've been doing this for 22 years. And that I ended up doing my training in England. And at the time, John Webb, which was one of the forefront spine surgeons, had done a bunch of what we call these Luque Trolleys. And so let me maybe share a presentation I sort of prepared that was sort of overview a bit of my personal journey and how, again, using sound logic and trying to really think this through, came up and sort of readopted an old technique, but maybe with new modern implants. And that so if you're okay, I'll just go ahead and share my screen. And then I'll talk to you about one of my favorite topics, which is early onset scoliosis. So essentially, modern Luque Trolley is what we call a self-growing construct for the treatment of early onset scoliosis. And I truly appreciate you giving me this opportunity to have a bit of a shoebox to talk about this procedure. And whenever I talk about this, I always sort of hit this home, is that managing early onset scoliosis is really, you want to control the deformity without compromising normal spinal growth nor pulmonary growth. And I don't care the shape, the color, or the nature of the deformity. First line for treatment of early onset scoliosis should always be casting/bracing. And the reason for that is that one could actually cure scoliosis, and it's because you're really harnessing the spine growth, and that if you do it early enough, you could actually cure it. If you capture it a bit delayed, then you may delay surgery, and by delaying surgery, you decrease the complication rate. As we know that each time you do an additional surgery, your complication rate goes up to 24%. And that really, behind all of this, it was the meta casting that sort of illustrated that if you have a child that has no associated syndrome, so it's considered an idiopathic scoliosis, if you're able to capture them or cast them before the age of 2, and if their curves are relatively small, but by relatively small, it's 60 degrees, you're able to, almost 3/4 of them resolve their scoliosis. And then, so she published that back in 2005, and the subsequent papers by Destu and Saunders that sort of showed the same thing, that out of 55 patients, 46 actually responded to casting and only 9 required surgery. And the value of this, and again, it's sort of the graph on the left, is really harnessing the power of early rapid growth. Now, if you've missed that window, well, it's still worthwhile doing serial casting. And we've adopted now sort of aggressive, again, like I was sort of talking to you about earlier, about double bracing, meaning that there is a Chenot type of bracing during the day that maximally sort of optimizes correction. And at night, you actually do a overcorrective nighttime brace. And that, so our casting, our wrister casting has actually dropped significantly, and we've just adopted this double bracing tactics for early onset scoliosis. But even if they show up a bit later, or even if they don't have idiopathic type, if you're able to initiate casting even after the age of 4 with severe COBs, you still have 21%, almost again 3/4 of your patients that avoid having this growth sparing surgeries. And again, that's again with the idea of sort of delaying this preventative surgery by controlling the deformity, and you're really just doing growth modulation, but with an external force. So then when you sort of say, well, when do you need to do surgery in early onset scoliosis, is the bottom line is when your conservative treatment fails, meaning that your conservative treatment is not changing or altering the natural history of the spinal deformity. So on the left, we have a child that, in 2004 presented, put her in a wrister cast, and 4 years later, essentially no longer had scoliosis. Now, on the same aspect, if you have a child that comes in, has a deformity, a severe deformity in 2007, a year later, the curve has almost doubled. And a patient was treated elsewhere, and they continued. And so it's actually, despite casting, despite serial casting, despite bracing, the curve is getting worse, but then you need to intervene. You waiting to try to delay surgery is probably a mistake. And to a certain degree, that's a bit of a different philosophy. And that, it's sort of like if the horses are out of the barn, you've missed your opportunity. And that's so as long as the curves are flexible, as long as the curves are not getting worse, well, then you should continue and persist with serial casting and bracing. Once the curve becomes rigid, once the curve is progressing despite, well, then you need to do something else. And that's where this idea of even Eduardo Luque sort of said, well, let's put an internal brace. Now, if you look at what are the current sort of growth sparing techniques, well, there's a whole panoply. There's quite a few options, but it boils down to that either you're going to try to distract in your concavity, meaning that this is the sort of representation of your scoliosis. You're going to try to expand or lengthen the inside of the curve, or you may decide to go on the outside, so on the convexity, and you're going to try to create compression. So you're going to prevent growth on the inside, on the outside, and allow the growth on the inside to occur. Obviously, there's differences. There's passive correction versus an active distraction, which is on your concavity. And then you could have a rib-based type of growing rod. You could have a dual growing rod, which is really spine-based, or you have this sort of mismatch, but they're magnetically controlled growing rods. Now, you have to realize that the construct on the left, they're cyclical and constrained, meaning that during the period where you're not distracting, the spine is not moving. Well, obviously, a rib base, the spine has more flexibility compared to a dual growing rod where it's rigid above and below, and that you immobilize, even with the magnetically controlled rods, you are immobilizing the spine. And therefore, that has some implications. The other thing that the implication has is that as you're actively distracting, well, you're changing the shape of the spine. And so what you're actually creating is you're creating kyphosis, because you're trying desperately to sort of lengthen the posterior elements, and therefore that's one of the concerns. Now your anterior implants, which are your tethers, and initially they came out with staples, which was abandoned because they were not as effective. But essentially, again, this has motion, and it's a unconstrained, so meaning the spine is still relatively flexible. But again, and I won't speak about that today. It has some advantages, but also has disadvantages. And one of the major disadvantages, if you do that when the children are too young, then you may actually worsen the deformity by inversing the deformity. So, so we published a paper in 2011, and we'll sort of get to it. But essentially in 2012, there was sort of, okay, well, what are the current surgical options for growth modulation? And there's really, so this is a table from the paper in JPO 2012, was essentially there's a distraction base, and then there you have your single rods, dual rods, your vector, your hybrid growth rods, and your magnetically controlled rods, which are the magic rod. And then on the opposite side is your convex compressions, which are shape, memory, alloys, and tether. And in the middle, there's this guided growth. And to a certain degree, what do we have as a guided growth are your Luque Trolleys and your Shilla. And I'll spend a bit of time explaining that. But again, so the idea is that on the left, you have a distraction type construct, which is posterior to base. On the right, you have this compression. If you look at growth guidance, the difference is what you're trying to do is really to control your apex. And what you want to do is you want to control and translate your apex. Because as you translate your apex, you're normalizing your growth plates. So the forces of your growth plate, instead of having some compression in a concavity and sort of offloading in your convexity, if you bring your apex across midline, well, then you sort of hope that with time, you're normalizing the Volkmann Euler law, and that you'll get symmetrical growth, so that you won't be getting this worsening cascade of wedging of the vertebrae because you've normalized the force across the apex. So again, so the idea of sort of modern Luque Trolley was to try to overcome some of the current treatment. So this is sort of the classic example, the current treatment options for early onset, so dual growing rods. You could achieve spinal growth, you can maintain correction. However, they continue to have a very high complication rate with a high rate of planned and unplanned surgery. So this little girl is a patient of mine that at the age of 1, her curve was already at 120. Essentially, her right chest wall was essentially entirely encompassed by her spine. And at the age of 2.5, we went and put in some dual growing rods. And then over the next 10 years, we were lengthening her. But that's 21 surgeries later. Essentially, we've created a iatrogenic spondylolisthesis at the base of the spine. So essentially, because of the excessive forces, she developed a isthmic spondy that actually went on to a grade 3-4 with radiculopathies in the lower extremities. Actually, during one of the lengthening, we actually induced a transient paraparesis. We had spinal cord monitoring. We sort of couldn't understand what was going on. And actually, the rod had migrated and was compressing against support. So there's huge patient impact on using these techniques. If you could think about 21 surgeries, yeah, the kid is still playing Little League and has good lung function. But obviously, this is not a great outcome. So Eduardo Luque, even 1976, sort of said, well, there's certain patients that, because of the curve and the severity of the curve, maybe we should be doing an internal bracing. And essentially, so he described this first technique using sublaminar wires without fusion. At least that's his thought was. That he did not actively go in and do a fusion, and would put sublaminar wires and sort of 2 anchors rods that would sort of expand. And essentially, this was designed for immature patients with severe progressive curves that were not amenable to bracing. Essentially, what we were talking to you a bit about earlier. And that their initial results, like everything else, the first 2-year follow-up seems to be great. The curve that was 72 was brought down to 22, and the spine seemed to have grown about 2.5 centimeters. Now, if you look at the long-term outcomes of this, essentially in 85 and 92, they came out with papers looking at so-called the results of Luque Trolleys. They had a high rate of spontaneous fusion. Kids were not growing, had a high implant failure, and they had poor control of the deformity. Essentially, the long-term outcome was really bad. And then, Pratt and all, which is essentially where I did my fellowship, was sort of looking at, they decided, well, in addition to trying to control the curve, doing these sublaminar wires and the rods, they said, well, maybe we should be combining apical epiphysiodesis. So in the apical epiphysiodesis is you stop the growth on the convex side and the long side, a bit like what the tethers are doing. So essentially what they did was that they would put in the Luque Trolley. So they had a cohort of 27 patients that had simple Luques, and then they looked at 18 patients that had Luque's and apical ipsiodesis. And this concept of apical ipsiodesis is exactly this idea of controlling your apex or doing a fusion at the apex, very similar to what Shilla sort of talks about. Different technique, but same concept. And then if you look at their cohort, essentially they had, a group of patients, again, small. So they had 7 patients that had purely trolleys. Average age was 7. They grew about 3 centimeters, which is 50% of what they were supposed to grow. They had a cob that started off at 48. They managed to bring it down to 25 in the span of about 4 years. The curve increased back up to 51. They went for a final fusion. The curve ended up at 41. Now, if they look at that compared to the patients that had apical control, which is this ipsiodesis, they actually had less growth. So they had 2%, 2 centimeters that represents 32% of growth, but they had a better curve control, not surprisingly. So they had a curve that was up at 65. They brought it down to 26. The curve did not change that much. It sort of creeped up again over a 4-year period up to 32 degrees, but still high complication rate, high failure rate. So during my time when I was studying with Webb, I was actually revising these cases. And what we found was that some of the cases really did well. And that, so if you look in this graph, so they actually had some cases that actually followed for quite a long time, and they actually had 50% of their growth. And others really did poorly, and they did poorly, especially when the implants failed. But the concept behind this Luque Trolley and the idea of, I said, well, maybe we could develop a new construct using modern spinal implants. And the ideal is appealing in the sense that you do one procedure, then you'd sort of, the implants would sort of keep the spine in check. And then you'd, get close to skeletal maturity, and you do a second surgery to get a final fusion, and that you've gained growth, you've controlled the curve. And so this is sort of the classic case that I did and published back in 2011 with a 6-year follow-up. So at the age of 6, the child had idiopathic type of scoliosis that had progressed despite bracing and casting. Spoke to the family, say, hey, why don't we try this internal bracing? And essentially what I used, again, obviously off-label, but we used a smaller diameter rod. So this screw has a bigger diameter that allows the rod to glide through. So it's a spinal anchor that glides. And then in addition to that, and again, very small, and you sort of see that there's sublaminar wires at the apex. And so there's 4 sets of rods. There's 2 rods that are attached at the top, 2 rods at the bottom, and they sort of glide. And then, so 6 years later, child actually was outgrowing his rods. So we did a revision surgery to, again, and when we took this, we obviously saw metallosis, which is because the metal and so on are rattling in there. But the child grew and the curve remained controlled, and that's what his clinical picture. So again, so the idea and the concept was we avoid repetitive surgery, the downsides of institutionalizing children with repetitive anesthesia, either, once or twice a year, you go and do lengthening procedures. And the concept is that you harness the passive growth or you harness passively the growth of the spine to avoid overloading the spine. And therefore, you're not actively distracting. And not only that, the construct is not locked. So your top rods are not bound to the bottom rods. There's play, and therefore you're minimizing that spontaneous fusion. And then so this is, another example that self-growth guidance works. And to a certain degree, the concept is that if you capture the apex, you don't want to fuse, or you don't necessarily want to fuse the apex, but you want to try to control the apex to bring the growth plates of all the spines midline. So here's this kid at the age of 6, another child. He had more of a congenital myopathy, had 1 surgery 5 years ago. Cobb went from 84 down to 28. And essentially over the next 5 years grew 5.5 centimeters. He's still growing, spine's still under control, and he hasn't had any revision surgery yet. And we're waiting for him to sort of 2 things. Either the curve will come back or he's finished his growth, and then we go ahead and do the final fusion. If the construct is still holding and there's no real issues, then we could actually just not go back. Here's another example. Again, at the time, 100% off-label. using a sort of a telescopic rod, which, if you look at the construct, it's really designed for a rib-based construct. But again, so the idea, 5-year-old, we go ahead and attach ourselves at the top and attach ourselves at the bottom. In the middle, there's this self-gliding construct. And at the apex, I put in this post. So it's a pedicle screw that sort of cantilevers the apex, brings the apex across midline. And on the opposite, I have this sublaminar wire. And again, we just let them go. And that's so from 2011 all the way up 2018, so essentially 7 years, no revision surgery. The curve is still maintained. If you look at the sagittal alignment, he has good sagittal alignment. And he's grown 6 centimeters over this period of time. So here's the different concepts. And again, we'll just use a bit of diagrams to sort of allow our viewers to sort of understand. So the classic Luque Trolley was patient would be brought to the operating room, would have a classic exposure. Not only would it have a classic exposure, you'd strip all the muscles off, and then you would have to sort of detach the ligamentum flavum, so you'd pass these wires. So obviously not very conductive to maintain growth, because we know that if you do that in children, they spontaneously fuse. And then you use these sublaminar wires, which are weak, that break, and you have this U-shaped construct. So spinal implants are old spinal implants that have issues and problems. And then I started experimenting, sort of using off-label concepts. I'm not the only one. There's other surgeons, and we'll refer that to a bit later, that essentially what we do is that we have a solid anchor proximally, and those are the red dots. So those are the fixed. So the rods are attached at the top and attached at the bottom. There's 2 sets of rods. And then at the apex, there's this overlap or gliding of your implants. And there's different ways of doing that. So you could use sort of sublaminar wires, or using an oversized screw that does not capture the rod. You could use a sort of male-female type of rod construct that has a telescoping rod within it that you don't lock, that you let glide on its own. And again, you could use a sublaminar wire to sort of pull it across, or this post, you put in a pedicle screw and you cantilever. So essentially what that means is that you, as you're doing the correction, you bring the rod, you attach it at the top, and as you bring the whole construct down at the bottom, then you're pushing the apex across on the right-hand side where the curve is. And then essentially, pairing up with the industry, we actually decided, well, this is sort of stupid. There's no real gliding construct in our toolbox. So I've been involved in developing a new implant that allows rods to glide, but they're still attached to a pedicle base. Shilla, the way the construct is a bit different. And so what they do, or the concept, is that you actually want to fuse the apex. So here, your fixed anchors are at the apex, and then you let your gliding construct above and below. And that's so what you need to do is that you need to leave your rods longer at the top and at the bottom. That may or may not cause some problems at the top or bottom as the kids are bending. Those segments are not fused, and therefore the rods may become prominent. The difference between the two is that there's a 4-rod construct, and the bank growth is really between what you have at the proximal and distal fixed anchors. So your growth is really in between those 2 sort of fixed anchors. Compared to your Shilla construct, is that it's a 2-rod construct. Value of 4 versus 2, questionable. Maybe 4 has a better rotational control, which again, we're still sort of trying to quantify and measure. And here also your bank growth is at the end. So the poles, so you have longer rods across mobile segments that may cause problems or pain. So these are just x-rays sort of showing clinical cases using sublaminar wires at the apex, 4 rods, and a oversized screw. Again, off-label usage. This is a vertical expandable prosthetic titanium rib. So it's the vector that is unlocked. So you don't put the clip that locks, but that you have that gliding mechanism. Again, and then this is the implant that I was involved in developing. Again, I have no royalties on this, or I have no return. That's why I have no shame about talking about it and recommending it to my patients. But again, it's still experimental, and we'll go over some of the results. But the idea, again, so it's a CE approved, and currently in Canada, special access. So there's no access in the US for the time being. And the reason is that I want to, and the team felt that Again, we're doing this in children, so do no harm. So we really want to make sure before we release this that it's really controlled. And then this is the Shilla construct where you have fixed screws. And again, they have oversized screws at the ends. That is also, it's a non-binding screw that is FDA approved. Ahmed Allah, who is a Palestine surgeon who's been advocating essentially a modified Shilla, where instead of doing a fusion across the apex, he constrains the apex, meaning that he is doing growth modulation by fixing the apex on the convexity. Again, that sort of has additional growth modulation, but leaving the upper ends and lower ends to glide off the construct. So the idea of modern Luque Trolley was really to use a new gliding spinal implant, new surgical technique to address the shortcomings of the old Luque Trolley construct. So here, in contrast to Luque, where he had these U-shaped rods that were sort of loosely fixed to the spine, you really want to have a rigid end construct. And that you're using 4 highly polished rods. 2 of the rods are fixed at the top, 2 of the rods fixed at the bottom. And that's really to minimize implant failure. And then, so what you want across the apex is you want a gliding anchor. And the reason why you want to actually put something at the apex compared to the classic dual growing rod is that you want to maximize the correction. You really want to try to bring the apex across the midline to normalize the forces of those growth plates. And then the third segment that we sort of developed was really limiting surgical dissection. And that's really to minimize autofusion. And so we published that in 2007. So I just want to show you a bit of a video of the surgical exposure. So this is the incision. So it's a single incision. The incision really has to be made over the spinous processes so that you don't have a skin incision over the implants. The implants are going to be on either side of the spine. And then essentially what you're doing is you're doing a transmuscular dissection. And the classic dissection of subperiosteal is really reserved for where you're putting your anchors. So at the bottom of the spine, you're going to go ahead and strip all the muscles off of the bone. And then so you're going to want to do a fusion so that where the screws are fixed, you're actually doing a bone grafting and fusion. Now at the apex, so you've marked before the surgery where you're going to want to put your gliding anchors. And across the gliding anchors, you do not expose the spine. So essentially you're developing a plane between the longissimus and iliacus and your multifidus and spinalis that allows you to really just almost like, so I call it a peekaboo sort of screw insertion, is that you really just want to go see the transverse process or really identify the entry point. And that and this, the whole idea behind that is that you minimize that fusion across the apex. So this is a picture where you sort of see that the middle of the spine is not exposed. And that's really a stark contrast to the classic Luque Trolley. And that, so the surgical exposure is really to minimize that. And then so at the end of the surgery, you've tunneled your rods, you've got fusion above and below that are fixed. And at the apex, you got gliding anchors that sort of bring the apex into correction. If the viewers want to see that, we've published also a sort of surgical technique, the neurosurgical focus video. And here's a link that sort of shows step by step. So from the patient being positioned, we typically put the patients in halofemoral traction so that we get maximal correction on the table, and that facilitates our procedure. So that's how we do it. So how have they been doing? So essentially, we have 2 cohorts. We approached the Health Canada, and they did not really see favorably to do a prospective study on this. So in Canada, we actually have done a retrospective sort of analysis of patients that had modern Luque Trolley. In contrast, in Europe, we did through the CE mark having the approval, we did a prospective study. And the difference between the 2 cohort is really that we went and with the great assistance with the pediatric spine study group, we managed to create a match cohort to sort of compare, because again, every child is so different that we tried to sort of identify patients that had different surgical techniques, but that we matched them on their diagnosis, the age at the time of the surgery, their gender, And then we looked at and curve magnitude. And then we looked at complication, reoperations, and follow-up. So the hypothesis was obviously that modern Luque Trolley would be using this engineering gliding anchor. And the thought would be that we'd have less complication, decreasing the planned and unplanned surgeries. The surgical indications are, patients that are essentially scoliotically immature. So they have to be between the age of 5 and 10, that have potential for severe deformity. So they have to have failed conservative management. So bracing has not worked. They have a deformity that we think that by the time that they're scoliotically mature, they have a curve that's greater than 80 degrees that we think have an impact on their pulmonary functions. Exclusion criteria is, again, just starting off, is obviously if the deformity is so severe, then like I was telling you, the horses are out of the barn. Most likely growth modulation, it's a bit like a bounce. The angular deformity is so severe that you're not going to be modulating that growth. So, and also if the curves are very rigid, another reason that things will not work well. Obviously, any patients that had the spinal surgery or excluded mature were excluded from the studies. So if you look at the Canadian cohort, so we had 20 patients that we followed, or that we retrospectively looked at. Mean average age is 8. And again, so we cheated on our inclusion criteria because, as you know, a 11-year-old may be fully mature versus significantly scoliotically immature. And then with time, we felt that the technique was beneficial and that we actually sort of included the patient that was less than 5. Again, this is just retrospective, so there's no protocol to be followed. Again, this was a discussion that I had with families, telling them that we had this new implant, that this was experimental, but that we'd be hopefully avoiding surgeries. We had done some sheep studies showing safety and efficacy. So I was comfortable suggesting to some of my patients, and we've been very slow. This, if you look at when we started this, our first patient was 2015. So obviously, this was really reserved for patients that I felt that the standard dual growing rods were not appropriate, or that the other techniques were not appropriate. Etiology sort of span. We had 3 idiopathic, mainly neuromusculars, and again, syndromic scoliosis. The average follow-up was 53 months with a minimum of 4-year follow-up. And this is just an example of an 8-year-old functional spastic diplegic who grew over 2 years, 2 centimeters. We're looking at the pre and post. So I'll be showing some clinical cases on the right and just sort of basic numbers on the left. If you look at the overall cohort, our average Cobb angle was 57 degrees, so a fairly big range of 39 to 97. And again, if you look at our, we sort of looked at our flexibility index, but our post-op Cobb actually average was brought down to 21. And this, again, a range of 5 to 37 degrees. And then if you look at our last follow-up, we see that the Cobb actually increased. So there is a trend to worsening or recurrence of the deformity. And that on average, that was for this cohort was 2 degrees per year. But again, a big scope. So we had some patients that actually had 25 degrees per year. And again, these are the neuromuscular curves that we did not manage to correct down to appropriate numbers. And that so factors that influence curve regression, or despite after doing the surgery, the curve came back, was residual deformity and also a low gliding implant density. So essentially, if we did not capture enough of the spine, well, the spine just continued to spin out. So at the top, essentially a 6-year-old congenital myopathy, had 1 surgery at the age of 5. Cobb went from 75 down to 10. Last follow-up was 10 degrees, essentially grew 5.5 centimeters across the instrumentation. So sort of poster child type of case. 7-year-old idiopathic, had 1 surgery at the age of 7. Cobb went from 55 down to 10, and then grew 3.5 centimeters across the apex. Curve increased up to 38. Had really sort of decompensated and essentially was no longer growing. So essentially was converted to final fusion. So what we found was that, again, and this is, just trying to highlight our experience, is that essentially when we looked at our growth modulation, what we found was a correlation of 0.5 that essentially showed that the greater we corrected the Cobb, the more patients would grow. And that if we had them under 15 degrees, they were actually almost growing their expected growth for that patient based on Dimiglio's predicted growth for the numbers of vertebrae that span, and that greater the residual deformity, less growth that they had. And that so on average, we had like 1 millimeter per year per vertebra of growth. And that, depending on how that sort of panned out, either they did extremely well or did extremely poor based on the residual deformity. Now, if you look at our overall complications, still a high complication rate. Again, this is a sort of new technique, so there is a learning curve. But that being said, out of our 20 patients, so 45% had revision surgeries. One had a prominent rod that we thought that was a problem with the implant. Turned out that the rod was poorly bent and that was becoming prominent. So we just had to sort of bring him back to the operating room, rebend and recontour the rod, and that was no longer prominent. We actually had 2 rod disengagements. So these are, if you look at the top right, you see that the rod on the right, the proximal rod, actually slid out of the fixed anchors. And that essentially that we noticed about 2 years post-surgery. So it was held for a while, then eventually became loose. And then we ended up revising him to final fusion. So we had 2 of those patients. We even tried, again, a bit, sort of pushing our scope, mesenchymal scoliosis, so children who had osteogenesis imperfecta. Again, families are very motivated not to have repetitive surgery, the risk of failure as you sort of go ahead and distract. These technique does not work for osteogenesis imperfecta. Their growth plates are not normal. We never got any of them to really grow. We had 2 patients that developed proximal junctional kyphosis. We think that, again, is poor sagittal contouring. So patient developed PJK that had to have revision surgery. And we had 1 superficial infection that required just oral antibiotics. Now, if we looked at unplanned return to surgery, we actually had 4 patients. So that's actually 20%. And that was 2 patients that required the PJK correction. And then we had 2 patients that had this rod disengagement that we went back, refixed them, and they continued to grow. We had 3 patients that had returned to OR, which is essentially converting them to final fusion. That was end of growth, or we felt that their curve had sort of progressed a bit like what we had seen in the initial Luque, that we felt just like the case at the bottom. We had a 7-year-old congenital myopathy, 6 years down the road. Curve had, again, pushing the indications of 95 degrees down to 30 degrees. And the curve had increased back up to 52 degrees, starting to have more pelvic obliquity. So we decided that after 5 centimeters of growth, we just converted to final fusion. And when we did the conversion to final fusion, we had greater correction and an additional 3 centimeters of growth. So again, when we do these and we keep the spine mobile, then the revision surgery, what we found is that there are a few areas that have spontaneous fusion, but nothing compared to the other dual growing rod that lock proximally and distally. And that it's fairly easy to go ahead and do more correction at the time of the final fusion. So obviously this study has significant limitations. If you think about it, it's just a limited case series. There's only 17 patients. There's no control group, relatively short follow-up, just 4 years. Out of the cohort at the time, there's 17 patients that are still growing. So the story's not over. Overall complication rate remains high. 40% of the patients had a complication. Some of them had to have revision unplanned surgery. And there was some spontaneous fusion, but not as much as other rod constructs. So second study was looking at this comparative match historical control group that we did with the PSSG. Essentially, we enrolled same indications. And essentially what we did is that we matched 18 patients that were done in 3 centers in Europe that had experience with Trolly, had experience seeing the new surgical technique, and that they recruited 18 patients. And we were able to identify 43 controls. We had, for every Trolly patients, we either tried to find a dual growing rod construct, a sort of rib-based construct with a vector construct, and 18 patients that had medically driven growing rods. And essentially what we did is that we made this sort of matching criteria that was automated, that looked at age, curve magnitude, etiology, and then we also had spine length and gender. So these are the results. So a very busy table, and we'll sort of delve into this a bit more in detail with subsequent slide. But essentially, if you look at the cohorts, so sort of lumping them together, which again is probably not ideal. And in the paper, you'll be dividing this much, by type of surgical procedure. But just again, just as an overview, the ratio male-female was essentially 50% in both groups. We had average age of implantation was essentially identical for our control group and our Trolly group, because that was one of the matching criterias. We had a similar proportion of idiopathics, neuromusculars, syndromic, and congenitals in our cohort. If you look at the preoperative Cobb angle, again, very similar to Cobb angle, because again, we matched for that. So some of the results, so if you look at the immediate post-op, Trolley seemed to have had a statistically significant smaller Cobb, which again, maybe we hypothesized because we're capturing the apex. But what's interesting is that the last follow-up, our Trolley group actually had recurrence of their deformity, and that compared to our controls, where the curve had gone down, had only gone up 1 degree. Now, this difference of 48 to 42 was not statistically significant. But again, to mention that in the sort of the current standard format, the Cobb seems to remain static. However, with the Trolley, there is a trend to worsening over time. If you look at the overall growth, again, if you look at pure numbers, Trolley seems to have a bit less growth compared to our control group, but again, not statistically different. What is statistically different is the overall additional surgical procedures. So if you look at our Trolley at the 3.5 year mark or 3-year mark, we really had only one patient that required a revision surgery, and that was because of the implant loosening compared to 120. But that, obviously being said, if you have dual growing rods, you're expected to go back every second year. Twice a year. Same thing with your vectors, you have to go ahead and distract. And then if we sort of break them down into unplanned surgery, again, marked difference between our Trolley patients and our control group. So if we sort of highlight some of those differences and similarities. So if we look at the additional surgeries at 3-year follow-up, which was our sort of endpoint of our study, we had 18 patients in a Trolley group. We had one that had the additional surgery, and it was an unplanned surgery because of a loose implant. If you look at by type, obviously your dual growing rods and your rib base growing rods had the highest repeated surgeries. But surprisingly enough, you had 8 revision surgeries in your magnetically controlled growing rods, which in part you're not supposed to have. And then if you break them down to the unplanned, looking again at the subset, things that really stand out, obviously, is that we have one unplanned modern Luque Trolley procedure compared to a total of 22, which again are mainly in the dual growing rod as well as your rib base sort of growing rods. Yet you still have 5 revision surgeries in 3 patients in your magnetic rod. So if you look at your Poisson regression showing a rate ratio of 0.4, essentially having a modern Luque Trolley, you had 96% lower chance of having a reoperation compared to your classic growing rod techniques, and that's at the 3.5 year follow-up. If you look at the overall growth, again, this is sort of showing our sitting height and standing height, because obviously some patients don't stand. Over the years, you see that it appears that Trolley seems to be following the same curve chart than your classic dual growing rods. Obviously, again, being as transparent as possible, and there's nothing like long-term follow-up that sort of dictates how things work out. Now, all our patients are continuing to be followed in the study. We wanted to have this interim analysis at the 3-year mark. So we do have patients that actually have 6-year follow-up. And so this table sort of is, here's our 18 patients. If you look at our cutoff of that first 3 years, there's really, so one patient has passed away, unrelated to the surgery. So he passed away 2 years out. But we did have that one patient that required a revision. Now, if you look at the 4-year follow-up, we have 14 of the 18 patients, and we have an additional 3 patients that had an additional surgery. 2 of them had a final fusion as they felt that the cob had increased to the point and they were close to scapular maturity that we just, the cohort decided to go ahead and do a final fusion due to curve regression. And then we had one patient that actually had overgrown the rod construct, so they had a revision to a ongoing, to a final fusion because essentially patient had grown sufficiently, actually exceeded the initial rod implantation, and the family preferred to just go ahead and have the final fusion. If you look at our, so that's our 4-year analysis, sorry. So we had 4 out of 14 patients. So 28% of the patients had a additional revision surgery. So that's the 2 surgeries at 4-year follow-up that, again, the modern Luque Trolley dictates. So we had 4-year of so-called controlled growth, so-called controlled cob measurement, and then they went on to have their final fusion. If you look at our 6-year follow-up, so out of the 18 patients, we have 7 patients that have gone out to 6 years. And that's out of these, 7 of the 7 patients had their final fusion 6-year out. So again, so the idea is what we're doing with Trolly is that we're minimizing the revision surgery, we're controlling or keeping the spine in check, and minimizing early fusion. So the take-home message is that self-growing rod constructs work. Modern Luque Trolley with gliding screws is one of the techniques. It can control curve progression. It does decrease and avoid repetitive surgery. The overall complication rate is actually lower than other publications. Now, that being said, the overall growth may be less than the expected growth. So that's a trade-off. And again, the best results are really correlated with maximal apical control. And that provides better growth and less curve progression.
Okay, thanks so much for putting all that effort into that presentation. It was terrific. So you must be pretty excited with the results in terms of, one surgery having, as good results as current systems with less complications.
So I'm definitely excited. They often call me doom and gloom. So I unfortunately sometimes sort of see the glass as half full, in the sense that the kids are still, so that's one of the idea that it boils down to what is the ideal patients for this technique. This technique is not all for all patients, and then. So one of the concepts is really choosing your patients, and to a certain degree, if you look at all the current treatment, that they will all tell you that you have to really choose your patients, and if you choose them well, they'll do well. I think that this is an additional tool in our toolbox. I think it has a role. Like I was saying, there's nothing like long-term follow-up to really get a better sense of what the technology is providing and how well it will pan out over the years. Mm-hmm. There is a skill set that, again, it is not a user-friendly. So your dissection and putting in your screws through a muscle plane in a deformed small spine. So currently I just use sort of freehand technique with fluoroscopic assistance. I think that, again, with the advent of navigation and robot, that will probably decrease your complication for people that are trying to adopt this technique. Because you have to be extremely sort of comfortable putting in pedicle screws at the apex of a deformity in a scoliotic spine. So again, it's just a word of caution. And again, this is a technique for centers that really do high-end sort of complex early onset scoliosis. And but so again, so I am happy, and even in our controlled study, surgeons being what they are, they tend to expand, and you want to expand your indications, and as soon as you sort of move away from your initial indications, well, you're going to ask for trouble. And so this, to a certain degree, at the basic concept, you need to have a child that's growing, that has failed conservative management, that you've lost the ability to control the deformity with a simple cast or serial bracing. And like we said, the publication shows that if you capture them early enough, they tend to do well. So again, this is not, again, putting in every patient that has early onset scoliosis. Um, Now, that being said, you want to capture them when the curves are not rigid and severe. So some of the patients just show up too late. And to a certain degree, like I was telling you, we tried in patients that had osteogenesis imperfecta. They don't really have, even though they're again ideal patients, they're small statured. You say, hey, it'd be great that we don't have to go back, bring them back. They have pulmonary issues and so on. It'd be great that we could sort of just put in an implant that would allow them to grow. They don't grow, and therefore this self-growing construct does not work. So this is not for that patient population. So if you have a deformity that's very rigid, that has, let's say, congenital deformity at the apex, you need to somehow drive that deformity. A self-growing rod construct is not going to work for those patients. So therefore, it's really getting a feel for it. You want to capture it when things are flexible. If they, so again, this idea of monitoring your patient closely. And when you think about, kids have idiopathic scoliosis, on average, they have 24 x-rays in their treatment plan. Any patient that you treat surgically, especially in early onset, you're now imposing a huge amount of radiation on these kids. So again, making sure that these centers use EOS, which is this low dose radiation. Again, a little pitch for my, one of the things that we've developed again is momentum. And that you were kind enough to sort of allow me to speak to you about that, and maybe the viewers can sort of look at that. But the idea of looking at ways to track and monitor these patients closely without using X-rays is critical, or at least low dose X-rays. And so there's protocols now, and even if you do use navigation, essentially you end up doing CT scans on these kids, and you may do two or three intraoperative acquisitions. So again, not really amendable, or again, high radiation. So using all our new technologies really needs to sort of keep in mind the patient and trying to avoid the amount of radiation and so on. So very challenging cases that, like I was saying, I started my career revising a lot of these trolleys and sort of understanding the subtleties about the technique and what worked well and what did not work well. There's more and more idea of capturing the apex. So Charlie Johnson at the Dallas, Texas Scottish Rite in Dallas has also came out with some papers looking at the ability, or tried to go in and really try to maximize that control of the apex. I'm not a fan of Shilla. It seems that they don't seem to grow that much. They seem to spin out a lot. I don't know if that's just because there's a two-rod construct. Again, McCarthy and his group has also a great publication looking at, and again, trying to find solutions to try to minimize the repetitive surgery. They, again, not wanting to, so medically driven rods are starting to fade out for different reasons. I was involved in, again, another company looking at, and again, the driving mechanisms, again, work well if you have a relatively small patient. And again, it's selecting that patient. So again, using appropriate technology for appropriate patients. Nice thing about Trolley is that you're able to shape your rods to match the sagittal profile. And that, so that's what, again, one of the great advantages is that, putting in a medically driven rod, there's a segment that's very straight, and therefore you have to exaggerate the deformities, i.e. to try to match the shape of the spine, and you get into trouble when you do that. So here, being able to sort of have a smooth ability to sort of match that's lateral X-ray, again, is an added benefit. The other added benefit, and to a certain degree, is this idea, and so when I do the final fusion, I do bending films, and you actually see on the bending films that through the construct they're still bending, and that's so there's still motion, and that's the idea of trying to minimize that surgical exposure, both in our animal study and in the clinical. Where you put in those gliding screws, you see that the facet above sometimes autofuse, because just your approach and exposure, you're at risk of opening that capsule, and that's so you put in that. Again, so the idea of putting in gliding anchors at every level, again, is worrisome. Putting not enough is also worrisome. So so again, so this technique is still in evolution. We are most likely looking at, well, not most likely, we will be publishing, our 3-year sort of follow-up, looking at a 5-year follow-up, and the study design was actually for a 10-year follow-up at the onset. So it's been a long, as we say, labor of love. But the idea is really to try to avoid causing harm to our patients.
It's great to reach out to and see Canadian surgeons being innovative, not only with surgery, but also with trying to move into technology that just patients and parents can use, which is Momentum app as well, Momentum Spinal as well. So I'll put links to those below, and patients can or viewers can check those out for sure. Thanks so much for your time. Great presentation, and you have a great day.
Thank you so much. Really appreciate you giving me the opportunity to talk on one of my favorite topics. Hopefully, manage to keep you entertained. So have a good day. Thank you so much.